Hereby I open this academic ceremony in which Rebecca Farah will defend the academic thesis, Cardiovascular and Pulmonary Rehabilitation in Lebanon. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Mr. Prorector, dear member of the Corona, dear supervisor, dear family and friend, in the coming 15 minutes, I will be presenting the highlight of my dissertation on cardiovascular and pulmonary rehabilitation in Lebanon. Today, the need of rehabilitation worldwide is largely unmet. In some low-income countries and low-middle-income countries, more than 50% of people do not receive rehabilitation service. That is the case of Lebanon, where rehabilitation is not routinely practiced. Despite evidence on benefits and international recommendation on cardiopulmonary rehabilitation, it's not available. No evidence and no previous research does exist for Lebanon to promote the implementation of cardiopulmonary rehabilitation. In Lebanon, evidence research and data are required. The aim of this dissertation is to provide evidence on cardiopulmonary rehabilitation in Lebanon to support policymakers in establishing cardiopulmonary rehabilitation, to have strategy and roadmap for future action plan, to increase access to rehabilitation service, to have more equity, to overcome barriers. In this regard, the following 4 research questions have been addressed in this dissertation. What is the evidence on access to pulmonary rehabilitation in low-income and low-middle-income countries? What kind of barriers to access cardiopulmonary rehabilitation are found in Lebanon? What are the knowledge, attitude, and practice of healthcare providers? And what are the preferences for cardiopulmonary rehabilitation of Lebanese patients? To explore this research question, the methodology used was, first, a systematic review done on pulmonary rehabilitation in low-income and low-middle-income countries. Second, 3 CAP survey conducted in Lebanon among different healthcare providers. Third, to understand and elicit the preference of the Lebanese patient, a discrete choice experiment survey was conducted. And finally, a short communication paper on the impact of Lebanon context on cardiopulmonary rehabilitation was done. So the first systematic review on the literature on pulmonary rehabilitation in low-income and low-middle-income countries was the first study. We focus only on pulmonary rehabilitation since a systematic review on cardiac rehabilitation worldwide have been conducted by Turkel Adawi and all in 2014. The aim of this systematic review was to highlight the presence or absence of pulmonary rehabilitation. The methodology used, we follow PRISMA guideline, include English study, prospective, retrospective, Gray literature from January 2000 till December 2021. The finding suggests that literature on pulmonary rehabilitation is limited, lack of know-how, lack of funds exist in low-income and low-middle-income countries, and a limited education. Conclusion, more research and action plan and action calls, are needed in this country. Then we conduct 3 different CAP surveys among different healthcare providers. The first one was among the chest physicians in Lebanon on pulmonary rehabilitation. Lebanon has a high prevalence of respiratory disease. It's #1 cause of death due to shisha tobacco smoke water pipe, according to WHO report in 2014. So this CAP survey, the aim was to assess and to understand the knowledge, attitude, and practice of chest physicians, and second, to identify barriers facing by provider. The methodology used was based on CAP framework, WHO CAP framework. It was the first study on pulmonary rehabilitation in Lebanon. It was based on 25-item questionnaire. in collaboration with the Lebanese Pulmonology Society. The questionnaire was discussed with professional healthcare provider. It was pre-tested, and comment and correction were integrated inside the questionnaire before to conduct the survey. The survey was conducted during a regional meeting of the Lebanese Pulmonary Society in the Bekaa Valley. The questionnaire was distributed without any regard to political, religion, and appearance to all the respondents. Results show that 1/3 of the respondents have good knowledge about nature and component of pulmonary rehabilitation. Pulmonologists fully support pulmonary rehabilitation implementation in the country, and they are facing several types of barriers to refer patients. The most important barrier found was lack of know-how of the only pulmonary rehabilitation program existence in Lebanon. Conclusion: role of physician in promoting patient enrollment need to be optimized. More awareness about the benefit of pulmonary rehabilitation for provider is needed, and implementing education in university is also highly needed. The second CAP survey was performed among cardiologists and cardiac surgeons in Lebanon. The aim was to assess knowledge, attitude, and practice of cardiologists and cardiac surgeons. Also, second, to identify what kind of barrier they are facing to refer patients. The methodology used was the same like the CAP survey among chest physicians. It was based on WHO CAP survey framework. It was a 25-item questionnaire. It was pre-tested, discussed with healthcare provider, and all the correction and comments are included inside the questionnaire before to conduct the survey. It was conducted in collaboration with the Lebanese Cardiology and Cardiac Surgery Society and conducted during the 4th Middle East Heart Failure Congress in Beirut. The results show that 41.5% of the respondents have medium knowledge about the content and the nature of cardiac rehabilitation. The attitude of cardiac surgeons and cardiologists, they fully support the implementation of future programs. And in practice, 53% of the respondents would refer patient to cardiac rehabilitation if the patient is stable at cardiac level. Conclusion: cardiologists and cardiac surgeons recommend to first to solve the financial issue before to implement cardiac rehabilitation in the country, and they need supplementary learning and education about cardiac rehabilitation. The last CAP survey was conducted among physiotherapists and physiotherapy students in Lebanon in collaboration with the Lebanese Order of Physical Therapists. The aim of this survey was to assess the knowledge, attitude, and practice of physiotherapists. Second, to identify what kind of barrier they are facing. And third, here we add the role playing by physiotherapists in prevention. The methodology used was the same. It was a CAP survey questionnaire based on WHO CAP survey. It was the first national quantitative cross-sectional study on cardiopulmonary rehabilitation in the country. It was conducted during a regional meeting of the Lebanese Order of the Physical Therapists and distributed hand by hand to all the participants without any regard to political, religion, and appearance. The results show that 45.5% of the respondents have good knowledge about the content. Also, attitudes were positive, and they believe that rehabilitation could improve quality of life of patients. In practice, physiotherapists are facing several types of barriers to treat patients. Conclusion: education programs need to be developed and implemented in university. Role of physiotherapists in promoting patient enrollment and program optimization is very important. Physiotherapists play a bridge between provider and patient, and they are acting a major role in the prevention. This slide highlights the financial and local barrier found based on the 3CAP survey. Political instability in the country lead to no reimbursement, no fund, no coverage from insurance. There is also local barrier like inflation of the Lebanese pound and no 24 hours electricity in the country, economical crisis, and no policy from the Ministry of Public Health. I will add the Lebanese people are struggling to survive against a stressful continuous factor since more than 20 years till today to access care. Lebanese patients need to overcome all this kind of barrier to access care today. The last study was a discrete choice experiment in Lebanon. The aim of this study was to assess the preference of user and non-user of rehabilitation service. The methodology used was based on a discrete choice experiment. We asked the patient to choose between two hypothetical rehabilitation packages. Which program do you prefer? The rehabilitation package were based on 7 attributes, which are attitude of the staff, travel time to the hospital, out-of-pocket payment, medical equipment, rehabilitation plan, additional lifestyle session, and support during the program. The results show the most 3 attributes chosen by the patient were first, friendly attitude of the staff, second, quality of medical equipment, and third, additional lifestyle education via e-health. Conclusion: patient-centered care is needed, and e-health could overcome some of the barrier to rehabilitation treatment in Lebanon. All the results found through previous study suggest the implementation of a new model of cardiopulmonary rehabilitation based on patient-centered care with an e-health component, giving the opportunity to every patient to choose between a traditional cardiopulmonary rehabilitation program and a hybrid one will be an added value and will increase the quality of care and access. This new model of hybrid one could be implemented in Lebanon, and why not in low-income and low-middle-income countries to access rehabilitation. Finally, the recommendation of my thesis suggests the need of rehabilitation is unmet worldwide. To increase enrollment, more education is needed inside Lebanese university. To increase access and overcome local barrier, a new model of e-health with patient-centered care component could replace the old one. To increase knowledge on benefits, more awareness campaigns are needed in the country. A call for international funds to increase access is highly suggested. Hybrid rehabilitation is an added value for Lebanese patients to increase the quality of life, access, and care. Hybrid rehabilitation will be useful and relevant for Lebanon. Thank you. Thank you for your attention. I will give back the word to the prorector.
Thank you. Thank you for your presentation. The opposition will be opened by Professor Scholz, Professor of Old Age Medicine and Chair of the Assessment Committee.
Dear candidate, my compliments for your scientific work, and of course also my compliments for your supervisors. I think your thesis is about a very relevant and interesting topic within the context of Lebanon. And I've read it with much pleasure. But of course there always remain questions. But to start with, please can you shortly explain for me the meaning of the beautiful picture on the cover?
Yes.
I think we all would like to know what the significance, yeah?
Highly esteemed opponent, thank you for your compliment. Thank you for your question. So here you have a heart. A heart means cardiac. And then you have a bike for rehabilitation.
Okay.
And then you have here a lung with one lung completely die and another one flourish due to the rehabilitation. And it's flourished in one cedar. The cedar, that is the symbol of Lebanon. So I hope it will reflect the
Yes.
my dissertation.
I like it. My compliments for that.
Thank you.
But I have to ask further academic questions. That's why they invite me for such a session. And the first question is about the general introduction. In the introduction, you refer to the core components of pulmonary rehab and also give the WHO's definition of rehab. And my question is, why didn't you refer to or use the WHO ICF model instead of referring to the core components?
Yes, because I think here we have cardiac and pulmonary rehabilitation. So I try to take all the main component of everyone and to mix it, because my thesis was on cardiopulmonary rehabilitation and not only on rehabilitation. So it was more, based on the component of pulmonary and cardiac rehabilitation.
But you still think that if you know the ICF model?
Sorry?
Do you know the ICF model?
Yeah.
But do you still think that these core components fit into this model?
Why not?
Okay, that's simply what I need to know. But okay, then I go further with the next question.
Thank you.
I want to ask you to look more overarching now after what you have learned from your studies. And if we look to the specific situation of Lebanon and the fact that cardiopulmonary rehabilitation is still in its infancy, and the fact that cardiopulmonary rehabilitation or rehab programs are not well accessible now, as you stated, what's your opinion then related to the future developments of cardiopulmonary rehab? Should Lebanon, next to improving knowledge and skills on CPR of the professionals involved, focus primarily on the development of community CPR programs, which might be more accessible and affordable, instead of focusing on the realization of more specialized rehab clinics? What's your vision about that?
I think we need both. We need to focus on cardiopulmonary rehabilitation and in the same time to implement center in the country, because there is a lack of both education and also lack of center in the country.
Yeah. But of course, I asked this question because of the specific situation in Lebanon. But
Yeah.
I was also, when looking to the 3 CAPs you performed,
Yeah.
I was especially impressed by the results on by the physiotherapists. So I think they are mostly ready to start as soon as possible. This was my opinion, or is it the wrong opinion?
No, it's right. So all the physical therapists have positive attitude about the future implementation of cardiopulmonary rehabilitation in the country. But the problem is the lack of know-how and the lack of education in this field. So till today, there is no master degree and formal training in the country and through all the university in Lebanon to have more skills in this field and also to have more specialists. There is a lack of know-how inside all the rehabilitation. So we need to implement more education and more awareness program about in this field.
You did these 3 CAPs,
Yeah.
in different type of professionals. Was there also attention for the interdisciplinary approach of CPR in the CAPs? And what is there already a basis for a good interdisciplinary approach?
For sure.
Yeah.
I think, yes, we need multidisciplinary approach to implement more cardiac rehabilitation with physicians.
But I want to interrupt you. We need
Sorry.
it, and you agree with me. I'm very glad about that. But do you think there is already a good basis for that? Is the attitude of the different professionals well enough to achieve a good interdisciplinary approach?
I think yes, because they have positive attitude. In all the CAP survey, we have positive attitude according to our result. All the providers want to implement more cardiac rehabilitation and pulmonary rehabilitation in the country. But there is some lack and gaps, and we need to first solve this kind of problem before the implementation. And I want to say more education about this field.
Okay, thank you. It's nice to see how much confidence you have in the professionals of Lebanon. I think it's very important to achieve good CPR. Then I would like to go to chapter 2.
Yes.
Chapter 2 is about your systematic review. And in page 31, you state we included RCTs, observational studies, qualitative studies, editorials, and systematic reviews. And in page 32, you also state we included grey literature. When I saw this, and I read it with much pleasure, the chapter, but I was thinking and wondering, did you actually do a systematic review, or was it more like a scoping review?
It was more a qualitative review.
So in
observational
fact,
review, I think.
Yeah. So more a scoping review, huh?
Yes.
Okay. So I'm glad you agree with me. I would like to give the word back to the pro-rector.
Thank you. The opposition will be continued by Professor Brooks, Professor Vice Dean and Executive Director of the School of Rehabilitation Science at Maastricht University, Ontario, in Canada. Professor Brooks was also member of the assessment committee, and we highly appreciate your participation to this academic ceremony.
Hi. Congratulations first, Rebecca. Marhaba. It's really great to see the progress that you've made, and I know that doing this work is not in any way easy in Lebanon. So congratulations for all your hard work. I have 3 questions. I noticed in your recommendations that you talked about virtual or e-health as an option. And I know that that was probably not on your mind when you did the study, because I think you did the study before the pandemic. And I'm wondering what your thoughts are. What would be some of the barriers to doing the virtual or hybrid? And even in your answer, if you can talk about the difference that you see between virtual and hybrid rehab for pulmonary and cardiac patients.
Highly esteemed opponent, thank you for your compliment and thank you for your question. The e-health, it's an added value. It will be an added value for the cardiopulmonary rehabilitation, I think. It's a cost-effective way to have care, and it's overcome barriers, above all the local and the financial barrier in Lebanon. Regarding the e-health, we according to all the study done in Lebanon, in my thesis, I can say that it was supported. We have a positive attitude in the 3-CAP survey about the implementation of e-health. And also in the DCE, we have e-health in the top 3 components. So why not to implement it? I read a systematic review on e-health, and they implemented successfully in Lebanon in 2 major hospitals in Beirut last year, and it was very successful. And now we have a platform where the patient can connect with the provider, they can check the test, and they can have an appointment and a consultation with the provider. But I think it's not yet done for the rehabilitation and physical therapist service. So yes, it will be, I think, a great option according to my result, but also we need to assess this component, and it will be maybe in future research. It was a starting point for Lebanon.
Great, and I'm really glad to hear that they have used it, at least in some of the hospital. Do you think it's different for rehab? Like, are you worried, for example, how would you assess physical function virtually? Is that an issue? Are you worried about safety when virtually you're exercising patients and the risk of that? Are those things that you think are of a concern when you're doing rehab virtually?
Okay, so I think first, e-health could not be an option for all kinds of patients. We have patients with a lot of comorbidity, they are confused, and other they would not take this option. So that's why the hybrid rehabilitation model is very important, to give the option to the patient to choose between a traditional one or a hybrid one with e-health component. And I think it will be an added value for this. So no, it's not, we cannot ask all the patients to go through e-health. Also, there is some patient, they like to come to the clinic and they need this social contact with the other patient, and they like to have face-to-face consultation and rehabilitation service. So at this point need to be assessed in further research, but it's according to the medical history of every patient, it will be different. Yeah.
Yeah, great. Thank you. That's great. My second question is, you might find this surprising, but actually, when I looked and read about the attitudes and practices of physicians and physiotherapists in Lebanon about rehab, they are not that different from some of the practices and attitudes of physicians and physiotherapists in Canada. For example, the lack of knowledge, that kind of stuff. And I wondered if you want to highlight what you think are main differences in terms of the practices and attitudes in Lebanon, and just from doing the research and kind of getting ready to do that study and afterwards. What are some of those differences?
I think it will be completely different because cardiopulmonary rehabilitation vary in the world in terms of duration, frequency, and session. A lot of studies show that in low-income country and low-middle-income country, it's different about the population treated. In low-income country, it's more HIV, and low-middle-income country, it's COPD patient with tuberculosis, and in high-income country, it's more COPD and chronic respiratory disease. Also, a study conducted in Europe and in America and Canada show that they vary too much about the number of sessions and the frequency. So we have to assess this point also.
Yeah, it's great points, very good points. But sadly, in Canada, we know that 1% of patients with COPD actually get rehab. So we tend to say, oh, it's so, and I know it's really bad in Lebanon because it's probably a lot less than 1%, but we have a long way to go as well in Canada in terms of access to rehab. So thank you for that. So I have one last question. So you talk a lot about changing attitudes and changing practices of individuals, of physiotherapists and physicians. And I wonder, what do you think the role is in terms of policy change? So instead of the micro, instead of putting all that responsibility on those individual health professionals, do you see any changes in policy that would increase access to pulmonary and cardiopulmonary?
For sure. First of all, we need to increase the practice. So we need to increase the knowledge of the provider. So as I said before, education and formal training are important to change the practice and the know-how about this field. I would add that formal training, like by example in Belgium, to open cardiac rehabilitation, we need to have a special license with physiotherapists who have this license, and then to make again this license every 5 years. Like this, we ensure that all the physical therapists are well trained and they have a good knowledge about the practice. So it was the first point. The second point about the policy change, I think that we need to implement policy and procedure at the discharge of the patient in phase 1. Of the hospital discharging. This moment is very important. It's crucial for the patient because the patient is going home and he needs at this time to have all the information about cardiopulmonary rehabilitation if needed. And all the studies show that this time we need to make a good coordination, and at this time I think the policy implemented in every medical establishment will be very highly appreciated for the physician, for physical therapist, and also from the patient perspective.
Thank you very much. I'll pass it on.
Thank you. The opposition will be continued by Professor Hayer Abu Saad, Dean of the Faculty of Health Sciences at the University of Belmont in Lebanon. Professor Hayer Abu Saad was also a member of the assessment committee, and also for you, we highly appreciate your participation to this academic ceremony.
Thank you, Mr. Prorector. I am delighted to be with you today. And I extend my congratulations to our promovenda here. And I've enjoyed immensely your work because you have written it very clearly and comprehensively. So I enjoyed every chapter of it. So thank you and good luck with your work. And hopefully we can make a difference really with your work on impacting the healthcare of Lebanon in the future, in the near future. I do have, in addition to my compliments, I have a couple of questions for you, and mostly clarification questions, because I would like for you to address the issue of psychometrics. You have used a questionnaire, a survey, and based on the CAP, and we know the procedure, but I want to know from you, how did you test it psychometrically? What kind of content validity did you do? Did you do cultural relevance testing of the questionnaire? And I know that you have done some pilot testing, but if you can elaborate on all these three issues, and if you have more psychometrics on it, that would be great if you can add a little bit more to that.
Highly esteemed opponent, thank you for your compliment and thank you for your question. Regarding the content validity of my questionnaire, I will start with this. All the questionnaires were pre-tested with professional healthcare provider and in multidisciplinary team before to conduct every survey. Also, it was based on WHO CAP survey, so it was pre-tested before to conduct the survey. And it was also pre-tested in different countries with this kind of questionnaire. The content validity was also based on a multidisciplinary approach, but it was not a pilot study. So maybe in further research, we could make a pilot study with different professional providers. But for every CAP survey, we discussed the test with physician, with a healthcare researcher and physiotherapist before to conduct the survey. Validity of
Rebecca, probably a follow-up question. Did you administer the survey in Arabic or in English to your participants?
So it was a limitation of the study. All the surveys were conducted in English, but all the respondents use well the English language in Lebanon. Make it another time in Arabic and French also.
Because I was going to ask you if you have done translation and back translation and all of that in order to make it more sort of culturally relevant. But if you have administered it in English to everybody, then you have answered my question. Thank you. My next question has to do also with some statistical analysis. I am referring to chapter 5, which was written very well, actually. I enjoyed reading it, especially when you did the study on physiotherapists and students actually working in the field. So I'm wondering if you have done any subgroup analysis to see if there is a difference between the two groups and what is the impact of this difference between them.
So regarding this chapter, chapter 5, it was a big chapter because we have a 61-item questionnaire in this CAP survey. So it was a bit different from the two previous. We try to make statistical analysis, but it was not significant regarding the subgroup inside the physical therapist and physical therapy student.
Okay. Let me move on to the next question, the last one, which is going to be sort of an overlap with the previous questions, but I'm going to address e-health from a different angle. We are currently actually conducting a number of community projects using telemental health, which is really also a combination hybrids and on-sites, mental health consultations, which is working well. But there are some, we have some problems with, as you know, the feasibility of doing something like this. So I'm wondering if you have thought through the e-health project that you talked about from a feasibility perspective. And how can we do that in order to make it happen effectively, to make it work effectively?
So I think before to ask the patient to go to e-health, we need to assess the patient at the clinic and to be clear with what kind of treatment we have to give him at home. And then we have to give advice to the patient and also maybe some technology to use at home also to be sure that the study will be feasible at this time. But during the time of the treatment, it will be recommended to the patient to come back to the clinic in the middle of the treatment to check the patient, to make an assessment in the beginning, in the middle, and then at the end, to be sure that the patient is following the right treatment and to check also how to say it, the better condition of the patient,
I think you mentioned something in your presentation. No, I think you're doing very well, thank you. You mentioned something that a number of hospitals are using actually e-health now, and that's correct. And it works very well, but I mean, we're talking about hospitals that are catering to the highly educated patient population in most cases, because that, you know, they can use the, you know, the e-health possibilities and they can manage very well. And I think that's correct. I mean, if you are aiming for that group, I don't think that's an issue. I'm thinking, you know, my colleague said something about community projects. You know, if you go out to the community, the expectation is, of course, very different. And the power connection, you might have power failures in these places. So I think that might be a big issue. And we are facing it now with the telemental health. So you need to take that into consideration when you think of doing something like this with an outreach modality. So you are outreaching to the community in remote areas where the population is not really very well educated, as you know, and they don't have the possibilities and the facilities that are available in the cities. Any comment from your side on this? How can you sort of make it happen?
I confirm what you just say, because e-health is not appropriate for all kind of patients. As I said before, I was talking about the medical history of the patient, but also digitalization. You know, for patients with lack of education, it's complicated, and we cannot ask the patient to go through e-health. So that's why we need to make an assessment in the beginning of the treatment and to check what are the preferences of the patient, if it's a hybrid one or more classical, traditional treatment.
Thank you. Thank you, Mr. Prorector.
Thank you. The opposition will be continued by Professor Evers, Professor of Public Health Technology Assessment and also member of the Assessment Committee.
Thank you, Prorector. Dear candidates, well, it was a pleasure to read your thesis. I would like to congratulate you. It's really a tempting subject and it's a tempting context. And it's also great to see that a number of articles also found their way to good journals. I would like to congratulate you, but also the people who supported you, your promotion team, but also probably also family and friends who help you. I was very interested in it, and I have several questions. And maybe I would like to start off the debate. You heard my chair is on health technology assessment, so I was very much interested in, the health economics aspects. And you talked about, the financial barriers, the paid and unpaid. And to my surprise, to start off, I wrote in the, or you've written down in the impact paragraph, that the healthcare sector in Lebanon could benefit from a cost-effective treatment like cardiopulmonary rehabilitation. And I was wondering, where does the cost-effectiveness come from? Could you say where it comes from as a starter, maybe?
Highly esteemed opponent, thank you for your compliment and for your question. Cost effectiveness of cardiopulmonary rehabilitation is well known because it's cheaper than surgery, and it gives a lot of outcome, a benefit to decrease the non-communicable disease, decrease risk factor for the patient, and increase quality of life of the patient. So according to all this, it's very important to have this kind of treatment as a cost-effective treatment.
Yeah, and let me go a bit with your line of reasoning, because you're saying it's proven cost-effective probably in other countries, or and that's why it's also cost-effective in Lebanon. That's your line of reasoning. I also have some PhDs in Lebanon, which do more HTA cost-effectiveness research. And also looking at the triple crisis which hit your country, it's the financial crisis, the corona crisis, and of course the accidents in Beirut. Would there be certain aspects, suppose that you together with one of my PhDs would continue in this work and do an economic evaluation in Lebanon, what would you consider to be important to consider? And I don't know what your expertise is on economic evaluation, but we could look at healthcare costs, but also patient and family costs and productivity losses, but also costs in other sectors. How would you advise my PhDs to continue on this if they would like to do an economic evaluation?
First of all, I think the healthcare costs in Lebanon now change a lot because of the inflation of the Lebanese pound. So international insurance, you have out-of-pocket to pay, and now it's too much because it needs to be paid in US dollar, and the salary are still in Lebanese pound. And so we can find a high difference between both. They didn't adjust the salary of the Lebanese population. And so it's not the access of care. We cannot have access due to that, first of all. So the inflation of the Lebanese pound, maybe we need to study the impact of this inflation on the care.
But then you're saying if I look at healthcare sector, then you would say I would not only look at what people are actually getting for healthcare, but also what they want to get, but they're unable to pay for that. Is that what you're suggesting?
Yes, I think yes. And we have a lack of study in this area. And I think it will be great to continue, and above all with e-health maybe, to assess e-health, because we didn't assess e-health.
Okay. And outside the healthcare sector, what would you then, if it would be an economic evaluation looking at the cost effectiveness, what would you consider then?
Why not? Why not? But I think Lebanon needs a lot of data and research in all the area, and it will be the starting point to start with the inflation, and also the impact of the war and the situation need to be assessed on the care, and maybe also on the financial barrier.
And are you thinking then on certain aspects which you would like to include?
Why not? The increasing of the cost on the access of care, because it was not evaluated before. So I think it will be great to assess the cost difference, the out-of-pocket payments, and to check if it was there is an impact or not.
Okay, yeah, great. One of the things that I know that's your probably triple language. Probably you speak Arabic, French, and English or not. So I was a bit surprised looking at your systematic review that you only selected publications in English, if I understood correctly, while you were looking at also grey literature in low-income and low-and-middle-income countries. So I was thinking, didn't you, maybe you were too critical, because I couldn't assume that a lot of these countries might have grey literature in French and Arabic, and which might highlight other aspects as well. So I was wondering why you decided that, and whether you came up with, in the exclusion, with literature which might have been interested, but you didn't include because you only were looking at English publications.
Yes, right. So we include grey literature in English study only because we cannot find in French, and in Arabic in low-income and low-middle-income country. And we focus only, it was an inclusion criteria to the systematic review, and we pick only the grey literature in English. We include the grey literature because we could not find trials and other kind of study in this country. So that's why it was very important to include grey literature.
No, I applaud you for including the grey literature. I think it's very important, especially with the but I'm a bit worried whether you're not too strict. I also, that seeing that you're able to manage some other languages, whether you not excluded a big part of the literature from low-income and low- and middle-income countries.
Because it was based on PRISMA guidelines, and so we include only in English and not in other language in low-income and low-middle-income country.
Okay. I think you could be a bit more liberal in PRISMA. I think you could also include other languages, but maybe that's for the next time. I also wondered a bit, I now go to chapter 6, your discrete choice experiment, which was nicely done, and you wanted to look at basically what was the viewpoint of patients. And here again, I was wondering a bit, because of course each discrete choice experiment starts with the identification of the attributes and the levels. And what I see there is that you mostly look at recommendations from the American Heart Association and American Cardiovascular
Cardiopulmonary Rehabilitation.
Yeah, that one. And I wondered, probably these kind of publications are written by healthcare professionals and not by patients. So maybe you missed certain aspects if patients would have been asked what are relevant attributes. But maybe I'm mistaken. So I was wondering, you look a bit at the clinical side of the literature, but you might miss some patients' relevant attributes and levels. So I was wondering a bit about that.
Okay, so the identification of the attribute were based according to the American Heart Association and the American Association of Cardiovascular and Pulmonary Rehabilitation, but not only based in according to these two organizations. It was based also on other kind of study done among patients with discrete choice experiments in rehabilitation.
Okay, that ascertains me that it's well done. And then the levels there, you just those were based, I think, on the expertise of you and your colleagues which were joining you in this, or did you also consult patients there?
Right. We have two levels, A and B.
Yeah.
The level A was the less attractive one, so 0, the code was 0. And the level B was the most attractive one, and it was 1.
Okay.
And it was based with the identification of all the attribute. Then we mix we make a generation, and that's it, between the level and the attribute.
Okay. Thank you. I'm happy with your answers, and I give the word back to the pro-rector.
Thank you. The opposition will be continued by Professor Spruit, Professor in Rehabilitation of Chronic Organ Failure at this institute. Professor Spruit was member of the assessment committee, and he is the secretary of the degree committee.
Thank you, Mr. Pro-Rector. Dear candidates, I also like to congratulate you with completion of a very interesting thesis on a highly relevant topic. I also like to thank you because on page 14, the first figure, you refer to me, but I don't think it's for me, the first figure. But thank you for giving that credit. But now we're talking about this picture on page 14. You say these are core components of the rehabilitation. And I partly agree with you because, for example, improved body composition is more an outcome for me, not a core component. So my question would be, for example, if you look at body composition, what would be then the core component of the rehab?
Highly esteemed opponent, thank you for your compliment, thank you for your question. Regarding the core component of pulmonary rehabilitation, we have a smoking cessation program, we have education through e-health or maybe phone call or SMS. We have physical activity for sure in the center, and we have psychological support and stress management, and also diet support regarding the body composition. The patient need to have more details and about the healthy lifestyle that he need to start. And also, if it's pulmonary rehabilitation, I think more pharmacological support about also oxygenotherapy and pharmacological treatment, education.
Okay, we agree on that. So the figure, I don't know whose figure it is, should be redrawn. I'd like to go to chapter 2, because in chapter 2, on page 37, you start with a very long table, and I have the feeling you mix all things together. For example, the population, sometimes it's COPD, then it's tuberculosis, then it's chronic lung disease, then it's outpatients. Can you take all these different results together?
This table, it was the finding of low-income country. And so we have to put all the study together. So that's why we have outpatient, inpatient, and different kind of population treated in the low-income country. So we could find COPD patient, tuberculosis, and etc. That's why we put all the findings in this table. And then after we have another table for low-middle income country.
But do you think that the effects of the rehabilitation are different between those different populations, or are they more or less the same?
No, for sure they are different.
But can you explain?
According to the patient, the population. So if we have a COPD patient, the pulmonary rehabilitation will be different if it's a tuberculosis patient, and about the timing, the duration, and the frequency. Here, the findings show that in low-income country, there is a lot of factor and the intervention of the factor, they are various. And about the frequency of the pulmonary rehabilitation, it's from 4 to 8 weeks, the duration. So it's vary from one country to another and to one population to treated to another. And in low-middle income country, it was about 10 to 20 weeks, the duration of the pulmonary rehabilitation program. So according to every population treated is different and country. We don't have a standardization of pulmonary rehabilitation there.
But could it also be because in one country they pay for 8 weeks, in another country they pay 20 weeks? It's not depending on the type of patient?
For sure.
For sure, okay. I'd like to go to chapter 3. That's the first CAP study that you present. And you ask the doctors, the chest physicians, to grade their own level of knowledge. What's a good level of knowledge according to you?
Yes, right. It's a self-assessment of knowledge.
Exactly.
So it's not objective. It's not an objective measure. It's a subjective measure. And I think it was like a perception of the knowledge about pulmonary rehabilitation, because there is a lack of practice in this field in the country. So it was a perception of how they feel about the content and the component of pulmonary rehabilitation, but it was not an objective measure.
But what's your definition of a good knowledge about pulmonary rehabilitation? When do you think a doctor or a physiotherapist needs training or not?
I think a good knowledge will have a high impact on the enrollment of the patient for pulmonary rehabilitation. And there is a lack of enrollment actually in the country, and there is a lack of know-how about the only pulmonary rehabilitation program in the country. So I think they need to increase the knowledge via awareness campaign and also education, free education for physicians, for pulmonary, for chest physician, and also for physiotherapists, to increase the knowledge. So there is not a good rate of knowledge, but when patients are coming to the pulmonary rehabilitation center, we will know that there is a good knowledge in the country about these fields.
What's your level? What's your level of knowledge?
Level of knowledge?
Yeah, about pulmonary rehabilitation. If you have to complete the questionnaire yourself, what would be your level of knowledge?
I didn't complete the question. I only
no,
construct the question.
I'm asking you now. Probably on the high side, I assume.
Yeah.
Okay, I'll help you a little bit. You don't have to be too modest. In chapter 6, you do a discrete experiment, discrete choice experiment. But I didn't understand which patients were included in the study. Can you explain it a little bit, please?
Yes. The timing of this DCE survey was very complicated because we start to conduct this survey from July 2020 till September 2020. And it was during the first wave of COVID-19. So the first wave of COVID-19 in Lebanon, everything like worldwide was closed, and above all, rehabilitation center. We include in the methodology 10 outpatient rehabilitation center. And due to this problem of COVID-19 pandemic, we got only 3 clinics to conduct the survey. And above all, I will add another impact of this study. It was a limitation. It was Beirut blast in August 2020. So in the mindset of the Lebanese patient, it was complicated for them to answer to a questionnaire and a survey. And all the Lebanese were shocked, and they were struggling to survive during the inflation, COVID-19 pandemic first wave, and also Beirut blast. So we include only 3 outpatients out of 10 in Lebanon, and we sent an email with the link of the questionnaire to the head of the physical therapist and rehabilitation center, and they sent to the population. Inside the population, we have 2 groups. The first group was the rehabilitation user. They make the rehab inside the center. And the other group was the non-user. They didn't start yet the rehabilitation.
But what type of, because you present age, gender, nationality, and so on page 111, but were those patients with COPD, asthma, heart failure?
We didn't assess this. We could not assess the type of pathology. It was only user and what kind of attribute they would like to have inside the cardiopulmonary rehabilitation program.
Rebecca Farah, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Make the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Rebecca Farah, the degree committee here present has assessed the quality of your thesis and your defense in view of its positive verdict and taking into account your previous qualifications. The degree committee has decided to grant you the degree of doctor. Professor Groot is authorized to confer upon you this academic distinction in accordance with the Dutch university custom. I invite your supervisors to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Rebecca Farah, the degree of doctor and grant you all the rights attached to it by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dear Dr. Farah, dear Rebecca, it is a great honor and pleasure to be the first to congratulate you with your doctorate degree. I also do this on behalf of Milena, of course. Both of us feel very proud about what you have achieved. You've written an excellent dissertation that increases our knowledge and insight on rehabilitation in low and middle income countries, including especially Lebanon. Your study also has great social relevance. For you, I think the completion of your dissertation feels like a great relief. You very much dreaded the defense today, and I hope that despite the anxiety that you had before the defense, you have enjoyed it as well as we did. It's, after all, the culmination of a long journey. A journey that started in 2017, when you approached us because you wanted to obtain a genuine and serious doctorate degree. A journey that brought you back to Belgium after the economic and security situation in Lebanon made it no longer possible for you and your family to remain there. I think it was with a heavy heart that you had to decide to leave everything behind there and move to Brussels. It was, however, also a journey that offered new career perspectives. You started to work at the Chirek Hospital Group Delta site, where you became responsible for the rehabilitation of patients post-surgery, and you were also enabled to do research on patients with respiratory diseases there. The research skills that you have developed during your PhD research, you can make now of productive use there. From our perspective, we welcomed our return to Belgium, as it had the added benefit that you could visit us here in Maastricht every now and then. That was especially attractive because of the nice Belgian chocolates you brought to us every time you came to visit us. For the rest, we have to thank Zoom Video Communications for hosting our monthly meetings. Despite that you have settled in Brussels, I think you remain attached to Lebanon. This is also evidenced by the cover of your dissertation, which you already explained during the opposition by Professor Scholz to us, which shows a picture of the cedar tree, the symbol of Lebanon, a holy tree representing perpetuity and peace. On the cover, the cedar tree is pictured with firm roots in the soil, although I understood now during the opposition that it was actually lungs, but I had interpreted as roots of the tree. I thought that they represented the roots that you have in Lebanon. The cedar tree is also known for its flexibility, and it therefore is frequently used to enforce houses in earthquake-prone areas. According to the Bible, the house of Solomon was made of cedar, at least partially. The flexibility of the cedar tree you also showed during your PhD research. I also already mentioned the flexibility of moving from Lebanon to Belgium and to restart your life and career there. It also required the flexibility of endurance, the endurance you need when riding a bicycle, as presented on the cover of your dissertation. Your research had a somewhat slow start as a cyclist, as you struggled quite a bit with the first paper, the systematic review of rehabilitation programs in low and middle income countries. Although for a while you got stuck there, you showed flexibility and brought your journey up to speed again by collecting data for the empirical part of your dissertation. You are a great organizer of data collection, and you managed to conduct not 1 or 2 surveys, but 4. One among pulmonary physicians, one among cardiologists, one among physiotherapists, and one among patients. By this, you collected data among about all stakeholders involved in cardiovascular and pulmonary rehabilitation in Lebanon. It was an enormous undertaking that you carried out next to your regular work and in a country that does not provide the most research-friendly environment, to put it mildly. Your PhD has been a journey with ups and downs. Or in the words of the Lebanese writer Khalil Gibran, that you quote in the statements, we cannot reach the enlightened summits without crossing the dark depths. For a while, it proved to be quite difficult to get your paper published in good academic journals. I think you got despaired over that for a while. We tried to encourage you, and we were right, and you showed resilience and flexibility. This paid off, and after a while, the first paper got accepted for publication, and then quite quickly, the others were published in good journals as well. This greatly encouraged you to finish the journey. 5 of your papers have now been published, and expect that the systematic review paper will soon find its way to a journal as well. You were also quite keen on presenting your work at conferences and to have the abstract of your presentations published in a journal. Your work also didn't go unnoticed. Although most have been published fairly recently, they already received attention and have been cited by other scholars. Finally, let me again congratulate you, Dr. Farah, for your excellent achievement, also on behalf of Milena. And we hope that although we have reached our destination now, we will soon embark on a new journey. We have already agreed to supervise some intern students on the research for the master thesis, and we have also made plans for some new collaborative research project in the hospital in Brussels. I want to take the opportunity to thank the members of the assessment committee, both those here present and online, Professor Huyer and Professor Brooks, for their efforts and work in evaluating your Rebecca's dissertation and in providing opposition here today. I also want to extend my congratulations to your parents being present here, your husband and children, who I assume are viewing this through the live stream online. Oh, your husband. Oh, I'm sorry. Oh, sorry. Okay. And to everyone here else, and to everyone else here present who has taken the time and to watch the live stream and to celebrate this joyful occasion with you here today.
Thank you.
Dear Dr. Farah, also on behalf of the University of Maastricht and the Board of Deans, it's a pleasure for me to congratulate you with this new degree you just have acquired. We can only expect that despite all the problems you mentioned in your defense, that your scientific work will contribute to the implementation of cardiac and pulmonary rehabilitation in Lebanon. And in the meantime, we wish you all the best and all the success during your clinical and research activities at the Edith Clavel Hospital Group in Brussels. Before closing this session, we will make a picture in the aula here before the screen, and thereafter we will go to the central hall, and there we will make a second picture on the stairs in the central hall. Hereby I close this academic ceremony.
Please come forward and bring your degree. Please join everybody. Maybe a few steps forward.
Recording stopped.
Very good.